Good afternoon, everyone, and welcome. My name is Jennifer Tani, and I'm the President and CEO of Healthy Schools Campaign. I'm delighted that you're able to join us for today's important webinar. Healthy Schools Campaign makes schools healthier places for children to learn and thrive by focusing on policies and practices at the intersection of health, education, equity, and sustainability. We work to ensure that all students have access to nutritious food, physical activity, mental, behavioral, and physical health services, safe outdoor spaces, and clean indoor air, with a specific focus on students and school districts in historically disinvested communities. We are thrilled to celebrate 2 years of federal investments in school Medicaid today. This month marks 2 years since the passage of key federal legislation, the Bipartisan Safer Communities Act, that laid the foundation for historic investments in student well-being and student health, including investments in the school Medicaid program. This is a moment to celebrate and also to continue our actions and keep building support for school health services. Every state and every school district has the opportunity to improve students' health and well-being, and we are inspired by the progress that so many of you are making. We are honored to have leaders today from Health and Human Services and the Department of Education join us. The efforts of both agencies over the past 2 years and their ongoing collaboration are a testament to the transformational moment we are in for school health. Their efforts to bolster and align education and health ensure more students can succeed and thrive. We are grateful for their work and leadership to promote student health and sustain school health services, and we look forward to a robust discussion today. With that, I'll turn it over to Healthy Schools Campaign's National Program Director, Jessie Mandel.
Thank you so much, Jennifer, and welcome everyone. It's so terrific to see so many people joining us from across the US. I am now excited to walk through our agenda for today. We are thrilled to have 2 guest speakers joining us to provide opening remarks. Dan Tsai, Deputy Administrator and Director with the Centers for Medicare and Medicaid Services, and Glenna Gallo, Assistant Secretary at the Office of Special Education and Rehabilitative Services of the Department of Education. Following their remarks, we will then hear from 2 leaders in the school Medicaid field, Christy Gwynn, Acting Bureau Chief with the New Mexico Healthcare Authority, and Kate Yeager, Director of Medicaid at Chicago Public Schools. They'll share their recent school Medicaid expansion and progress. First, a few reminders. We are recording today's webinar, and we will email out the recording, slides, and additional resources following the webinar. Also, you can submit your questions at any time. You can ask questions to the speakers through the Q&A or share questions or comments to all participants through the chat. We'll do our best to answer questions, and if we don't get to a question today, we'll follow up with you after the webinar. School health services are critical to increasing students' access to healthcare and key to advancing equity and reducing the barriers to care too many students across the US continue to face. As we know, healthy students are better learners, and when students have access to health services, including mental and behavioral health and substance use services, they have improved health and academic outcomes. There are different models of delivering health services in schools, and they play complementary roles. Some schools partner with community-based providers where outside providers, including Medicaid providers, come in and offer services, and some schools operate a school-based health center with a clinic located in or near a school. When we talk about the school Medicaid program, we are focused on providers who are employed by or contracted by the school district to deliver services in a school setting. Medicaid can reimburse for services provided to all Medicaid enrolled students when provided by eligible school employed providers. As we'll hear from our speakers today, the school Medicaid program is a key way to increase and create consistent federal funding for school-based health services. While many schools and states face budget cuts, workforce shortages, and limited resources, school Medicaid can fill in gaps and increase resources. And what's more, it's an opportunity for new thinking around how Medicaid and education systems and policymakers can work together to address needs and improve outcomes for students. It's now an honor to introduce our guest speakers. Dan Tsai is the Deputy Administrator and Director of the Center for Medicaid and CHIP Services at the Center for Medicare and Medicaid Services, where he leads the center in addressing disparities in health equity and serving the needs of individuals and families who rely on these essential programs. Before joining CMS, Director Tsai was the Assistant Secretary for Mass Health and Medicaid Director for Massachusetts, serving for 6 years. Director Tsai brings extensive experience across Medicaid, Medicare, and working with stakeholders to design and implement innovative models for healthcare coverage, delivery, and payment. Glenna Gallo is the Assistant Secretary of the Office of Special Education and Rehabilitative Services at the Department of Education. Assistant Secretary Gallo has more than 25 years of experience supporting students and adults with disabilities. She served as the Assistant Superintendent of Special Education in Washington State and previously as the State Director of Special Education for the Utah State Board of Education. In her state-level education leadership roles, Assistant Secretary Gallo provided expertise in the improvement of public pre-K through 12th grade special education programs. And before her state-level education leadership roles, Assistant Secretary Gallo worked as a classroom teacher and administrator. Following their remarks, both speakers will join us for a few questions. Director Tsai, I'll turn to you first. Thank you again for being here and joining us.
Thanks, Jesse. Can folks hear me okay?
Hear you.
All right. I just came off stage off a thing and I'm in a small closet basically at this piece and it says my internet connection is unstable. So I apologize in advance, but I'll just say a few things briefly. First, thank you all for convening and pushing and continuing to keep our collective focus along with, I guess, 280 participants really focused on how we maximize the potential of school-based healthcare and school-based services. So it's really important to this administration. We and our colleagues at ED and all across HHS CMS are really excited and focused on this. So I think as folks know, well, we in Medicaid and the Children's Health Insurance Program, we cover a little over 50% of kids in the country. And when you look at kids of color or communities of color and lower income kids, that number in some cases jumps to 80%. And so we want to figure out how to make sure across states there is as much access to primary care, preventative services, mental health, behavioral health services, and a range of specialized services for kids. And one of the best places to make sure that for delivery is in school-based settings. And we know that historically, there's both a range of policy choose to accept or utilize Medicaid in schools. We know there's a bunch of administrative burdens and other things as I've talked to districts and administrators and school nurses and others for why utilizing Medicaid in school-based settings is really complicated. And so for all of that, we've spent a tremendous amount of time with a lot of input and advocacy and support from you all and others in the community to do a few things. One, modernize how our policies, what it takes to actually claim for Medicaid in school-based settings, things within our regulatory and statutory authority. We think we could, we're able to make a little bit easier, and we put a lot of that out. And second, in partnership with our colleagues at ED and the community. And second, just with support from some appropriations from Congress, I think yesterday we released grants to 18 states for working with their LEAs and others to really support expansion and strengthening of school-based services. Every state gets at least $2.5 million. Each of the 18 states, I should say, at least $2.5 million over the next 3 years. There's a technical assistance center as well. And there are a lot of things that the grantees are trying to do. In some cases, states are trying to expand. I think many folks on this call know what I mean by the free care pool, but the free care option or expanding school-based Medicaid beyond just kids with an IEP. Quite a number of states are wanting to do that and to work through all the administrative pieces, are willing and able to utilize, and the ability for mental health, behavioral health, substance use disorder services in school-based settings, and to figure out how to use that funding to work with LEAs and schools to make sure that some of those services can be expanded. I'm looking at a list of pretty exciting, impressive things that those 18 states are wanting to do. And so we're really excited about that. Our team is highly committed. I see Kate Yeager's about to speak also, and she and others have really provided a lot of input and support to us. So thank you for that. Richard Kimball from our team is on. And I guess all that to say, we think school-based Medicaid is excellent. It's awesome. We want to expand it. We think it's exciting. We know we need to do so within the Medicaid statutory framework. That's very important for our congressional oversight and such. And at the same time, we are wanting to make sure we're able to provide support and reduce barriers and partner with our colleagues at Ed and others. So I think, Jesse, I should probably stop there, and I'll pass it back to you all.
Thank you so much. And thanks for jumping from one presentation to the next. So we're thrilled that you could join us for this one. No, it's great. I'm now going to turn it over to Assistant Secretary Gallo to provide some remarks, and then we'll bring both of you on for some questions. Assistant Secretary Gallo, thank you so much for being here today.
Great. Thank you so much. First, I'd like to thank the Healthy Schools Campaign for inviting me to join all of you today for this important and timely webinar. The Healthy Schools Campaign has been an incredible partner to the Biden-Harris administration in our efforts to get more mental health services and supports into schools across the country. We have been so lucky to be able to work closely with you, and specifically Jesse Mandel and Lena O'Rourke. I also want to thank Deputy CMS Administrator and Director Dan Tsai and his whole team for their leadership. I'm going to echo some of the things that Dan said, but we've really been able to model the type of intentional partnership between education agencies and health leaders that we need to see everywhere across the nation. This partnership has been geared towards addressing and reducing barriers to accessing reimbursement for Medicaid services in schools. And we're excited to continue these efforts, and we recognize the importance and the impact it has. Hopefully, those of you that are attending today have heard Dan talk about it, have heard me talk about it now. And as you're sitting here today and you're listening to these presentations, we're hopeful that you're going to be able to identify additional issues that we can work on together. There are a few areas where the leadership and the partnership is definitely more critical now in addressing youth mental health. We know that the emotional and psychological well-being of individuals promotes healthy development, functioning, and increases the capacity of individuals to live productive lives while striving towards reaching their full potential. A major aspect of the school environment includes promoting the mental health of all students and the provision of programs and services to address those needs. School mental health programming includes an array of services that addresses the prevention, early intervention, and treatment needs of our children, students, and youth to facilitate well-being and positive, healthy youth development. It's never been easy to be a young person, but right now we know that we're dealing with a youth mental health crisis of historic proportions, especially coming out of the pandemic and endeavoring to recover from that. Suicide is the second leading cause of death for people ages 10 through 14. That's devastating. We know too that young people are 6 times more likely to access health and mental health services when they're offered in school. So let's just take a moment and reflect on those statistics, right? Suicide is the second leading cause of death for people ages 10 through 14, and young people are 6 times more likely to access those services when they're offered in their school. That's a big deal. Schools are a natural setting for the provision of programs and services that meet the mental health needs of students. Schools strive to create safe, caring, and enriching environments that foster healthy student development, positive academic outcomes, and reduce problems. School-based mental health services allow mental health needs to be addressed without removing students from the learning environment. That's why this is an issue of equity. And that's why we need to make sure that schools are a trusted place for all families and communities where they feel comfortable seeking services like mental health services. This isn't true for all families and communities, and we need to keep working together until it is. And that's why I'm so proud that the Biden-Harris administration has made historic investments in school-based mental health. Here at the Department of Education, we've been focusing on getting more mental health service professionals into schools, and not only getting more into schools, but getting the professionals already in our schools trained and creating safer and healthier schools overall by driving out our school-based mental health services grant program, our mental health service professional grants, and our Stronger Connections grants. All of these have been made possible because of the historic Bipartisan Safer Communities Act, or BISCA, that President Biden signed into law 2 years ago. We have already awarded more than $500 million in grants through these programs, and we're thrilled to be awarding another $70 million later this year. All of this is geared at getting more than 14,000 additional mental health providers into our schools. But we know that these competitive grant programs are short-term, and schools also need long-term solutions to sustain these crucial services. So we've been working closely with CMS to put funding for school-based mental health services on a sustainable long-term footing by making it possible to get reimbursed through Medicaid for providing those services. Right now, as you know, only 13 states have fully expanded their state Medicaid plan to cover more students, including and beyond students with disabilities. And I applaud those 13 states. But this is another reason why I work and why these new CMS grants are so crucial to increasing that number and for providing support to states to create urgency around this issue. You heard a little bit about my background, and as a former state official in Utah and Washington, I recognize that state Medicaid agencies and state education agencies have a lot on their plate. And I recognize that there are challenges to collaborating across and among agencies. That's why the Biden-Harris administration is working around the clock to get you more resources and support to help save the lives of children and young people in your states. What could be more important right now? I know that many of you, most of you who are on this webinar already get that and already see the importance of this work. And I'm so excited to recognize that these new 18 CMS state grants are powerful and are able to access money to address their differing needs. For states that received a CMS grant, we're ready to work with you to get your plans enacted that will expand, enhance, and improve implementation of Medicaid school-based services in your state. Here in the U.S. Department of Education, we're focused on assisting state education agencies and local education agencies with this work. We have our team ready and trained and willing to provide expertise and to help problem solve with you And we also want to offer space and opportunities to help you learn from each other, such as in a community of practice. Let's work together to conquer these needs in a powerful and productive manner. For states that didn't get a CMS grant, you can still do this work. You can build important relationships and partnerships with your SMA, your SCA, and LEAs. And when you have that team in place, utilize the Joint Technical Assistance Center between CMS and ED for help, examples, answers to frequently asked questions, and so much more. We have been working together as a collaborative team to develop and make resources and opportunities available to support you to do this work. And we recognize the commitment that's needed to youth mental health and Medicaid school-based services across the nation and within each state. And don't forget that there are other opportunities as well to get funding, not only through CMS, such as in these grants, but through the U.S. Department of Ed, such as the grants that I've already spoken about, our school-based mental health grants, our mental health service provider grants, full service community grants, grants through the Individuals with Disabilities Education Act, and more. So as we think about the next school year and all you're doing to prepare, whether you're working at the state level, in a district, or in a school, I want to leave you with an ask. I feel strongly that when we come together to learn together, we need to leave committed to doing something with that new knowledge. And so I want to challenge you to think about how you're partnering with families. We've all been incredibly focused on interagency partnerships, working across health and education sectors, and that is important. But we definitely cannot forget our families. And so I ask, how are you ensuring that your families are at the table and have an opportunity to share their experiences and their needs? How are you ensuring that schools are working with Medicaid providers to have a clear understanding of each child and family's plan of care so that they can coordinate that care across systems? We can't go into this in silos and only understanding and worrying about our specific sphere of influence. We have to come together, and our top goal is to remove barriers and connect children to care wherever they need it. Families are integral to our success. They must be partners in this. So please consider ways to intentionally build relationships, bring them into this work, and coordinate with them as we improve service delivery to their children. Personally, as a parent who has needed to partner with the local education agency to bring necessary and emergent mental health services to my child, I cannot emphasize this partnership need more. This is something that we need to make sure we have pathways, not only for proactive supportive planning and conversations, but to address emergent crisis needs as well. I encourage you to drop into the chat, if you have an opportunity, some ways that you're connecting with families and working across agencies to further these efforts. This work isn't easy, and we're so glad to be your partners in it. I would like to thank you for prioritizing this and for everything that you've done to get us here today. Because of your efforts, we are saving children's lives and making our schools stronger, safer, and more prepared. With that, please keep up the great work and remember the ask of you that I'm doing to bring in families and their perspectives. So thank you so much. I'm also going to scroll the comments because I asked you to drop in some ideas there as we're thinking and as we're working through the rest of today's presentations. Thank you, Jessie. Back to you.
Thank you so much, Assistant Secretary Gallo. I really appreciate the call to action and everything you share to really ground us in this conversation today. I know you have to hop shortly, so I'll just ask one question and then Director Sai, if you're able to stay on for a minute more, then we'll turn it to you to answer if that works. So, you covered a lot of these ideas in your remarks, but thinking about the upcoming school year, what are some recommendations you have for schools and states to put into motion to begin to keep making progress for student health?
Well, I'm going to start and then hopefully Dan will jump in too, because I think he probably has some good ideas around the same thing. But as an educator and as an administrator, it's always nice when I go into the next school year to kind of think about the framework and the support structures that we put into place that we can use throughout the school year. And so knowing that we need to focus on mental health and student well-being as we go into the school year, I would be thinking about what is the information that I want my staff or my team to know about these services and what's available? Where do I want them to go if they run into barriers or have concerns? And how am I getting this information out to my families as well? So as from an education perspective, I would be thinking about the frameworks that I can build on, whether it's a multi-tiered system of support. How can I build into a positive behavior intervention and support plan? How is it that I get the training and the information available to my educators, to my school leaders, to my families, and then students, because they're such an early warning system themselves, right, as they interact with their peers. And so I'd be thinking about how to frame all of that and how to build in kind of a continuous plan, do, study, act cycle of looking at the resources. Am I meeting the needs? Where are the barriers and how would I address those? And then working with partners across agencies. Like, I'm going to turn it over to Dan because I'm thinking he probably has something to add here.
Thanks, Glenn. I think, well, yes, I mean, for state agencies, the biggest thing, this is not specific just to the fall, is we want to work with you together with Ed Technical Assistance Center to help states be able to expand services through school-based Medicaid. And that's both formally by adopting options for the free care pieces. Again, I'm using terms that I'm assuming most folks on this call know, but if you don't, there are all sorts of ways to expand the usage of school-based Medicaid and to take up some of the, if you haven't already, some of the simplifying types of things we try to release in our recent school-based Medicaid claiming guide with the goal of reducing administrative barriers and burdens for schools to be able to leverage school-based Medicaid. I think overall for LEAs as well in schools for the fall, this is not just for the fall, but mental health care for kids, of which you mentioned, we think we've got a crisis around immunizations, making sure kids are having access to primary care. And we've got still, especially with some of the Medicaid renewals that have happened across the country, we have kids who are not covered with insurance through Medicaid or the Children's Health Insurance Program, CHIP, or other forms of coverage, and really helping to make sure there's awareness of that. And lastly, I'd emphasize states working in collaboration with LEAs, because all of the wonderful claiming and other guidance on the back end won't have an impact if LEAs do not feel they're able to fully implement, handle, and take advantage of kind of the opportunities there.
Thank you for that. Assistant Secretary Gallo, I just wanted to make sure that, do you have time for one more question or, okay, great. So are there other efforts, you mentioned a few, but what are some of the other efforts within CMS, within CMCS and OSERS that impact child and adolescent health that you wanted to just lift up, especially for the school Medicaid community you have here today?
So you know what, there's so many. I'm kind of struggling with what else I could provide that would be helpful. And I think for me, it's not about replicating or adding activities. It's about using a framework to roll out information in an easy to use, accessible manner, right? And so for that, I would think about, we have grants that we put out around stronger connections. We've also have TA centers that support not only the TA center that supports Medicaid work, but TA centers that support behavior and positive behavior, as well as other evidence-based programs. We have technical assistance that's available through the Department of Ed, not only through the TA center, but from our state leads that work with each state and their educational agency. So that is helpful. And then for us, one of the things that we're working on right now with CMS is kind of a technical assistance document that really addresses kind of the myths and facts around school-based Medicaid reimbursement. And so for us, it would be incredibly helpful for us to know the questions that are coming up and the barriers or perceived barriers that you're hearing about from either agency or families, so that we can target that TA specifically to your needs.
Director Sy, would you like to share it too, just some of the other efforts at CMCS?
Or I'll be folks, what we're focused on at CMS is, in this administration, is making sure that kids can get it's easy for eligible kids to maintain their coverage in Medicaid and the Children's Health Insurance Program, including when they're renewing. There's a ton of stuff there, including new regulations that we put out that and the ability for states to put a waiting period in for certain kids before they can get coverage and things of that sort. So we want eligible kids to be able to be easily enrolled in the program. And pre-pandemic, we had a percentage of kids who were eligible but not enrolled. Once folks are enrolled, we want kids to be able to access mental health services, pediatric care, primary care, behavioral health services in a timely way. And there's a ton of stuff I could talk about, but those core things are it's kind of back to the basics for us. If you're eligible, make it easy for folks to get enrolled and stay enrolled, and make it easy and not rocket science for a parent to help navigate the healthcare system to get their kiddos the services that folks need. And then we emphasize that kids have special statutory rights to get access to all medically necessary care, which can also be delivered through schools. And that is a really important piece. So we cover 56% of kids in the country. And so we spend a lot of time thinking about kids. And so we really appreciate this partnership.
Thank you both so much for your responses, for thinking about the connections and lifting up the perspective of families and the through line to getting kids covered and enrolled to the services. So just and we just really appreciate you both for being here and for the work that you're doing together and thinking about how we can really ensure that all kids are getting the services they need and staying healthy. So I could keep asking you questions, but I think we should let you both go. I know how busy you both are. We're so appreciative that you were able to join us. And there's remarks that keep coming in, so we'll make sure that you get those comments in the chat too, and get you that feedback as well for you and your team. So.
And I see some Kate Guinness, Richard Kimball on our team here. There's a TA center link that I think Richard put in for folks to direct questions to. We are highly engaged on monitoring that. And so thank you all. Thanks for having us. I'm sorry I'm dialed in from this closet at this conference. So take care.
Thank you for joining wherever. And we'll put those links again. I know Richard did share those, but we'll make sure those get out again, and all the resources that you shared. Thank you both so much. Have a wonderful afternoon. Thanks.
Great. Thank you.
Thank you so much, Assistant Secretary. I'll now turn it over to my colleague, Allison Paxson, who will introduce our next speakers. Thank you.
Thank you, Jesse, and good afternoon, everyone. So just a quick recap before we get into our next speakers. The grants are really a very important step for school Medicaid and student well-being overall. As we heard from our speakers, not only do the grants represent a significant opportunity and investment in access to healthcare for more students, but they also represent a significant commitment for building greater collaboration across state education and Medicaid agencies and school districts. We are in a new era for school Medicaid, and the administration is encouraging all states to comprehensively expand their school Medicaid programs to all eligible students and services and the widest array of school health providers. And ultimately, one of the key points we really want to reiterate here is that all states have the opportunity to improve student well-being by better leveraging Medicaid, no matter where they are in the process of expanding the program, and regardless of whether or not they have received one of the new state grants. For states that have not yet expanded or only partially expanded, this is an ideal window of opportunity to act now to comprehensively expand your school Medicaid program. For states that have taken action already, this is a time to keep moving forward with implementation and enhancing the efficacy of your program. Tapping into these opportunities on the table today is critically important to promoting health equity and supporting all students to experience greater lifelong well-being into the future. And which is why, if we move on to the next slide, I'm especially excited to introduce our next two speakers, Christy Gwen and Kate Yeager. These are two school Medicaid leaders who will share their experiences expanding school Medicaid without a grant, how they did it, the lessons they learned, and the results they're seeing now. We hope this additional context of their state's pathway to school Medicaid expansion and implementation will help illustrate the best practices and opportunities available for all states and school districts seeking to advance school health services. And so our first speaker this afternoon, Christy Gwen, is currently the acting bureau chief of the Exempt Services and Programs Bureau of New Mexico's Healthcare Authority Medical Assistance Division. She started her state Medicaid career in 2012 as the New Mexico School Health Manager and also spent 6 years as a district level coordinator for the Medicaid School-Based Services Program. Christy also has served in various positions on the board of directors for the National Alliance for Medicaid and Education, or NAME, including as president in 2019, and she is currently the NAME Governmental Affairs Committee chair. And so following Christy's remarks, we will also be hearing from Kate Yeager, who serves as the director of Medicaid for Chicago Public Schools, one of the nation's largest school districts. Kate has more than 20 years of experience in public policy across various disciplines at the state and local levels in Illinois, New York, and Tennessee. Currently, Kate oversees all Medicaid programming at Chicago Public Schools, including service capture and claiming, quality assurance, and federal and state policy and advocacy efforts. She also currently serves on the NAME Board of Directors and is an active member of the Governmental Affairs Committee. Kate, Christy, thank you so much for being here with us this afternoon. We'll have a few minutes for Q&A following your remarks, but let's go ahead and get started. So Christy, I will hand things over to you first, and then Kate, please just jump in when she concludes her presentation.
Thanks, Allison. Happy to be here today and share our experience from New Mexico in terms of expansion. So we can move on to the next slide, please. New Mexico, I've always said, was not an early adopter of the expansion to non-IEP services. However, when you look at the fact that only a handful of states have expanded, people have told me, yes, we were early expanders. Our journey to expansion for non-IEP services started in late 2020 in the midst of the pandemic at the request of our education department and the office of our governor. The Human Services Department, as we were then known, began work to evaluate the expansion to non-IEP services, and we set a target implementation date of July 1, 2022. And so when we started looking at the expansion to services and talking with our LEAs, there were a couple of things that really came to the forefront in terms of potential issues and barriers that we saw with this expansion. That included, lack of social workers in our state. We were dealing with a lot of just crisis intervention, and our schools were really unable to provide quality mental health services because they were constantly just dealing with these crises. We were not able to always provide ongoing services after that initial crisis. And we knew that the collaboration between our outside providers and the school providers did not exist to allow continuity of care. As we were thinking about the pandemic and what would happen as we came out of that, we also knew that there were going to be a lot of unknowns that were going to result as our schools returned to whatever the new normal was going to be. And so trying to anticipate those additional needs for mental health services, we knew that there were students who were going to be afraid because of the pandemic, potentially had been in unsafe or abusive home situations, had lost family members to the pandemic, as well as other stresses in the home that could potentially all present themselves in addition to the needs we were already seeing before the pandemic. And another big issue that is not unique to our state has been a lack of funding for providers for both IEP and non-IEP services. In New Mexico, we have a lot of areas that are considered rural and frontier. So, sometimes it was geographic constraints or current models for providing services that really provided barriers, as well as ongoing funding needs needed to be able to provide staff at the current recommended ratios. So we were talking about the fact that funding for social workers, counselors, school psychologists, not always fully supported by our funding formula. And so our LEAs are having to identify additional sources to fund those needs. And in many cases, they were not able to support the current needs for IEP services, much less be able to expand outside of that, despite a desire to do so. Providers just weren't there, and or the funding just wasn't there. One of the strongest things we have is collaboration between the New Mexico Medicaid Department, our Education Department, and our LEAs. We have always worked really well, and as we talk about, the National Alliance for Medicaid and Education being what we refer to as a three-legged stool with representation from all of those areas, our state very much functions in that formula as well. So we have contacts at education we work with regularly. We have regular communication with our LEAs. So we were very easily able to form a state team, join the Healthy Students Promising Futures Learning Collaborative, and start to move our work forward toward the expansion in the midst of a pandemic and all being done remotely. Next slide, please. So when we talk about our path to expansion, of course, one of the most important things was the submission of documents to CMS. So we knew that we were going to have to do a state plan amendment as well as revisions to our implementation plan for our time study. We did contract with a vendor to assist us with that process and, leaned on them heavily for policy guidance as well as things within the documents that were related to the systems we were using that were going to need to be updated in order to conduct our time study and our cost settlement methodology in order to include non-IEP services. So between early 2021 and 2022, we did a lot of that work, making the revisions of these documents, thinking about the changes that we wanted to make, the areas that we wanted to expand into. And both of these documents were submitted to CMS in March of 2022. And as you can see from the approval dates, it was about a 15-month process for us to have the conversations with CMS and negotiate on changes that needed to be made to both of those documents in order for us to gain our approvals. Keep in mind, our effective date was July 1 of 2022. So we received approvals that were retroactive to the beginning of the 2022-2023 school year. And I'll say, some of the colleagues from CMS are on the call today. I feel like we were negotiating these at a very interesting time because CMS was also working on the guidance. And so, for example, our SPA was approved, and I believe one of the last ones to be approved prior to the issuance of the new guidance. They were actually issued, the guidance was issued, and our SPA approval letter was received on the same day. And one of the things that we ended up doing was revising our transportation methodology to be in compliance with that new CMS guidance. So one-way trips, which had been a different methodology from what we were currently utilizing, we went ahead and negotiated that into the SPA so that we would be in compliance with that new CMS guidance. There was also a lot of negotiation within our random moment time study implementation plan around the potential changes to the notification and response windows in anticipation of that new CMS guidance. I will say that the implementation plan is the area where we are going to have to go back and submit revisions to come into compliance with that new guidance. And we did receive that approval in early May of 2023 as well. So we had some discussions with CMS and, had been able to continue to run our time study under what had been our currently approved plan. And then we will be making changes to the implementation plan at some point in the future to come into compliance. And simultaneously, while we were having these conversations and discussions and negotiations with CMS around the potential changes, we continued to collaborate with our LEAs to develop a lot of technical assistance and necessary documents that were going to be needed for the non-IEP services. So we created a new combined parental consent template that our LEAs could utilize for both IEP and non-IEP services. So working within the existing constraints of the federal requirements, creating a form that would serve both purposes for IEP and non-IEP services, so that our LEAs did not have to try to navigate which form needed to be used depending on what services were being provided, whether it was IEP or non-IEP. We worked to create several templates specifically for behavioral health services for the non-IEP side, because one of the things we knew is these services were being provided, but not necessarily being documented consistently. So our LEAs who are providing IEP services, a lot of them, as in many states, use third-party billing vendors, but the non-IEP services were not being captured in that same manner. So we talked about what potential kinds of service plans could be developed, specific forms related to crisis intervention that would serve to meet the needs for medical necessity for Medicaid billing, and service documentation templates that would be consistent, again, with the requirements needed for Medicaid, as well as determining potential additional CPT codes that would be needed for our interim claims billing for non-IEP services. So as many states function under a very limited list of services or CPT codes for IEPs, we knew that there were going to be some additions that needed to be made to support these non-IEP services. So really evaluating what those potential codes were, determining potential additional interim rates for those codes, and getting that all into our MMIS system, as well as communicating with our vendors for the billing side, so that everything would be in place for the LEAs to utilize. Next slide, please. So when I think about how far we've come in 3.5 years, it just seems unreal to me that we've made it through the other side of not only a pandemic, but the actual expansion. Happy to have had our first year of cost reports completed and finally be able to share some results from where we ended up at the end of the first year. So many of our LEAs expressed some hesitancy to submit their interim claims for their expansion services. And I think, there were a variety of reasons that they were unsure about documentation, that their providers were going to be, maintaining all of that to the level that would be needed. In many cases, they were just wanting to kind of sit back and see where things kind of shook out after the first year. I think one of the things the LEAs may not have realized is that if their staff were participating in the random moment time study and they were providing non-IEP services, ultimately they were going to be reimbursed because of the cost report methodology that we used. So it did not matter if they submitted those interim claims, if they participated in the time study and their providers said they were providing a direct medical service that could have been IEP or non-IEP, they still got reimbursement for those services. We also had LEAs that were looking still to, again, meet that need for additional behavioral health providers. So they were looking for additional funding. They were just flat out looking for providers because we have a known provider shortage for behavioral health in our state. or those providers were in the districts, but not being included in their time study. And so, we've made sure that we've worked with them, providing support and training for what is appropriate documentation to support that billing and the random moment time study. So our state has started to audit our random moment time study, and we're looking at moments that are coded as direct medical services, and we're asking the LEAs to provide that documentation. Whether or not those interim claims are submitted, we want to ensure that we can support those moments in a way that's appropriate to ensure that our time study is accurate. So when we came to the end of the first year, our cost reports for FY23 were submitted this last December, in December of 2023. And after they were all completed and everything was said and done, we have attributed slightly over a 10% increase in our cost reports to the expansion to non-IEP services. A little over $6 million for expansion was received by our LEAs. And I think there's two things I want to point out in this. A total of little over 4 million for non-IEP services, which I think is huge. And an even more astounding 2.3 million was received by 9 districts or LEAs that were reported delegating nursing services. So that was another place where we expanded providers to include delegated nursing. That includes services that are being provided under the supervision of an RN, that could be health assistants or classroom aides that are delegated to provide those nursing services, medications, administration, and so forth. But only 9 districts had their providers appropriately listed in their participant list to capture the reimbursement in that category. So $2.3 million was huge. And of course, we experienced other increases as most states have continued to do, just related to increased costs that would have impacted both IEP and non-IEP services. So I think 10% in an increase for the expansion for our first year is pretty significant. As we started to assess the results of the cost report and these financial implications, we definitely identified the need for continued training to our LEAs. One, so that they could understand how claiming with the cost report works, as I mentioned, that they know they're still getting reimbursement and be able to ensure that documentation is sufficient to support the time study moments. And again, this work to identify delegated nursing providers. We worked with our vendor to reach out to the LEAs. And I think one of the things that I pointed out is anybody who's in an LEA that has a health assistant or someone else, and our nurses in the state agreed, they virtually should all be in that delegated nursing services category. And so working with the LEAs to ensure that those providers were categorized correctly so that in this coming year for the FY24 year, they will be able to capture that additional reimbursement, and we should see some significant additional increases to our cost reports. And I think also just ensuring that our LEAs, are well aware of all of the programmatic requirements. We've also already started talking about the potential changes that are going to need to be made to come into compliance with the new CMS guidance, and getting them thinking about what that's going to look like so that when those changes are made, we will be in a good place with training for their providers to continue to be able to move the program forward. Our big thing is we want to ensure that we support our LEAs in whatever they need to ensure that those actual providers that are boots on the ground have the documentation requirements, understand the time study, understand all of the obligations that the LEA has back to the state for documentation and compliance, so that, should CMS or OIG decide they want to come visit and take a look at our state program, we have all of our ducks in a row, to mitigate any potential audit findings. Next slide, please. So with that, we've just provided the contact information for our team here. We have an entire team that supports our school-based Medicaid program. Vanessa, our manager. We have Liza and Ashley, who are 2 program managers, and a financial analyst, all of whom are happy to provide information more on the program, specific things that we do. And, we're happy to support other states in this work as well. So with that, I will turn it over to Kate.
Thanks, Christy. Jesse or Allison, I don't know if anyone wants to jump in just regarding the time in our plan.
Yes, we're planning to go a few minutes past the hour. Thanks, Kate. We encourage you all to stay on because Kate has some very helpful and exciting information to share about CPS in Illinois. And as a reminder, this webinar will be recorded. So if you do have to hop off, please join us. We'll share the ending. So Kate, take it away and we'll put that reminder again in the chat.
Thanks, Jesse. Hi, everybody. As Allison mentioned, I'm Kate Eager. I'm the Director of Medicaid for Chicago Public Schools. This may be the greatest professional challenge of my life to cram all of this into a couple of minutes. For those of you who know me, know I like to talk. So what I'm going to do is give a brief history of Illinois and our SPA and what it includes. And then we just in the past couple of weeks received our cost settlement information and our expansion data from our first year of implementation. So I'll be sharing that for Illinois and CPS. So next slide, please. So just as quick background, this has been a very long process for Illinois. Before the SPA was submitted, we easily had a good 4 or 5 years of advocacy to get this done in the state. But it was submitted to CMS in September of 2021 and retroactive beginning that fiscal year. So as of the beginning of the school year in 21-22, we were operating under certain conditions of the SPA. So essentially the information and new requirements were coming through Public Consulting Group, who is our state's Medicaid vendor. And over the last 3 years, it has been a rolling process of new requirements, new opportunities until the SPA was approved. And so as of this past school year, 23-24, was our first full year of knowingly operating under all of the new requirements and opportunities. So the interesting thing about Illinois is that we submitted our SPA along with a couple of other states. And while the SPA was pending, the updated school Medicaid guidelines were released from CMS. So our SPA and a few others were held in order to ensure that all of the new requirements included in the new CMS guidelines were included in our SPA. So while it was, a slight level of frustration on our end with the elongated time period, in the end, I 100% believe that that was the best move. Illinois is now in compliance with everything, and it didn't require us to have to go through the SPA process again. So the SPA was finally approved in April of 2023, and I will talk about what was in it on the next slide. So in our SPA, there were a couple of key things. So first is reversing the free care rule. And in Illinois, so we expanded eligibility from students with IEPs, IFSPs, only to any Medicaid enrolled student for any allowable service deemed medically necessary. We also expanded our list of school-based providers. So we added 5 new provider types, which you can see listed there. The other big piece, we moved from a rate settlement to a cost settlement reimbursement methodology. The third piece, we implemented some major changes to the random moment time study. So as part of cost settlement, the requirement is that any staff that we are seeking reimbursement for must be included in RMTS. So all direct service providers and all administrative staff are now included in RMTS. Our RMTS period was also extended to include all regular school days. So we moved from an October, December, January, March, April, June calendar to the first day that staff are back in school. So it's typically about a week before students return to school through December. and then January, March, April, June. And we also increased the sample error rate from ±2% to ±5%. And then it also provides the specialization transportation claiming requirements as outlined in the CMS guidelines. And so all of these things were rolled in over time over the 3-year period. So this 2 minutes of presenting, I won't go into details about that, but it was very learning as we go, or finding out something new that we had to do that quarter. But as I mentioned, this last school year, everything was completed and everything was done this school year. Next slide, please. So I'm going to jump right to impact and money, which is what we all care about. So we just, as I mentioned, we just received in the last couple of weeks our cost settlement information for fiscal year 22. And all of this good information comes from PCG. I don't know if Peter is on, but the summary in Illinois, so in fiscal year 22, we had 870 LEAs and JAs participating in the school Medicaid program. The total direct service reimbursement came to $200 million. So the fee for service or interim claiming throughout the million, and then the payment that receiving was totaled a positive of $93 million. Of that $93 million, we know that $18 million makes up the totality of the free care expansion as it was implemented by districts in fiscal year 21-22. And so what I mean by that is that because the SPA was not approved, we weren't submitting interim claims for the free care expansion. So this takes into account our costs. So we can say that the 18 million represents the free care rule reversal for fiscal year 22. And I know specialized transportation is a hot topic for all of us right now. And so the cost settlement payment takes into account the revisions in transportation claiming. I will note that while that $9 million looks like a very scary number, at that time, we had not in the state implemented the interim claiming process to reflect the revised specialized transportation claiming. So this is doing all of the implementation of the new calculations based on schools submitting their claims business as usual prior to the SPA. So moving forward, that $9 million should not be that large of a number. And then just overall summary. So 81% of the districts are receiving additional reimbursement through cost settlement, and 19% of the districts are in a recoupment state. And so there's a handful of reasons for that. I don't have time to get into them anymore, but we do fully expect that recoupment number will go way down moving forward. Next slide, please, and I'll wrap up. And then so these are the impact numbers for Chicago Public Schools, which for those of you who heard from me when this came out knew I was giddy for about a week. So Chicago Public Schools, just to put some framing around this, we enroll more than 340,000 students. We have about 2,100 direct service providers providing about 5 million services a year, plus our 1,500 or so administrative staff that are included in administrative claiming. And just to note that we currently are not claiming for our school health aides or SICAs or paras. So that's what these numbers are reflective of. So our total direct service reimbursement ended up at a little under 52 million. So our interim claiming was around 25 million, and then our cost settlement payment was nearly 27 million. Of that 27 million, the free care made up 4.6 million of that. And I will note for CPS that free care for us during fiscal year 2022 represents our 504 plans. So that's what we were ready to do and at that point in time. So this doesn't include any of our expanded service providers. Again, we're not billing for school health aides right now. So that $4.6 million is really representative of our 504 plans. And then for transportation, CPS did get dinged on that. We did claim for $2.6 million in fiscal year 2022. About 730,000 was recouped. So our final reimbursement for transportation was 1.9 million. And then that combined with our AOC claiming of about 26 million means that our total reimbursement for fiscal year 2022 was more than $77 million. So I will just stop there because it's 2:08. And Jesse, hand it back to you. I know I can keep talking. So, thank you.
Thank you, Kate. Kate, thank you again for staying a few minutes over. As a reminder, we are recording this, so we will send out the specific link since I know some people are hopping, although I know many people actually have stayed on because they wanted to hear your numbers and your results. So thank you so much, Kate. And Christy, thank you so much to you both. Kate and Christy, do you have a minute more since we're already over time? I know we've got people that are staying for any questions. And Kate, I just want to, again, those numbers are amazing. and so we will be sharing this information out, but I really feel like the information that you both shared is hopefully very encouraging to those of you just getting started, and we're just thrilled to see the results. Are there any questions? I'm just taking a quick look in the chat. One quick question that did come through is just, have these funds allowed districts to maintain or increase the number of social workers or staffed post-COVID dollars? And I know it's kind of early but just I'll let you both answer those questions or how you might be thinking them going forward. Kate, why don't you start? Kate, you start.
Yeah. So I think, and I've talked about this before, and I know this is not the same and for all districts and a luxury for a district like CPS, but when we look at our staffing needs and requirements for all of our 650 schools, we did not base our hiring decisions on any of the additional aides. So if a school district wanted a social worker or 2 social workers or a counselor, like we budgeted for that for the purpose of not in 2 years all of a sudden having to get rid of those additional supports. So it's not the way that we looked at it. It's not the way that we currently look at funding schools. So that didn't, and I know that is a luxury, right? There's smaller districts, there's rural districts where the extra funding could go to that. And then now that funding is leaving, there's a hole, right? But that was not something that we considered in making our staffing decisions.
And I'll say, we've tried to encourage our LEAs to do the same thing, right? So, you think about Medicaid funding coming in and, we've got all this additional funding and we should hire staff, but it's kind of soft funding, right? Like, you need to think about it in those terms that it might not always be there at the same level. So I would say, I think some of our LEAs have utilized some of the additional reimbursement to try to support those dollars. But we, from the state perspective, have tried to make very, very clear to them that they should not always count on that funding being there at that level. So, doing what we can to caution them, I would say, about utilizing that or ensuring that they have enough to be able to carry those salaries for, several years going forward. But I do think some of it is being utilized to hire additional funding. And the other thing we've done is really try to continue our advocacy at the state level, right, with our education department to think about how they support additional funding, ongoing funding for our LEAs to provide behavioral health services.
Thank you. Are there any next steps that you all, like, now that you've, oh gosh, that was the wrong way. where if you had to, what's kind of top of mind, where are you ready to go from here now with these results? Not, okay, you don't have to give us your full, extremely packed agenda, but where's sort of top of mind? Yeah.
Yeah, I'll jump on that. So I think for Illinois, it has been such a whirlwind the past 2 years. Like we would literally be in the middle of a quarter and it was like, oh, hey, this is how you're doing specialized transportation now. And like, before the SPA was approved, and we still don't have an updated LEA handbook. So we're relying on information from the state and as it comes out. So everything was very fluid over the last 2 years, and we had to be very reactive and flexible, and to make sure that we maintained compliance. So I think I mentioned that we're not currently claiming for school health aides, which is anywhere from 3,000 to 5,000 staff, which would be a huge amount of money. But when we switched to the requirement of having everyone included in RMTS, we knew that program was not in good enough shape to have them included in that. So it was very reactive, very responsive for us. And I think now that we know all of the factors and all the parameters, we are looking at, okay, how do we revise the processes do we put into place to make sure they're improved and the best they can be, since, we kind of just did it. And then we're also working on actually including the expanded service providers. So that's something that for a district as large as CPS, we've got new service providers that are in departments that have never been exposed to Medicaid before. So we're looking at educating them and looking at their IT systems and what they're using to document services, and are they Medicaid compliant and that kind of thing. So we're about halfway through that list of getting folks onboarded, but that's very recent as of the second half of this past school year, with getting new provider types on. But lots of other things, but I think, and I love it because for me, it's always like, great, what's next? I'm a big West Wing fan. So, but I think it's really revising and looking at what we've done to date and kind of taking a breath. And then, there's lots of policy and other issues that we want to take up that I will not mention, but, so staying on that front as well. And then, continuing to implement the optional opportunities that were included under free care.
And I think for New Mexico, we are looking at our guidance document, which we do have a pretty strong, what we call the guidebook, but our staff are taking a good look at that this summer in terms of places that we really need to try to beef that up, to support the LEAs, working with our billing vendors who get lots of questions. So, we made changes last year, but I mean, as Kate said, kind of a little bit reactive in that, we were getting approvals, we were going through this, we put in what we knew we needed to put in, but are there things we could probably strengthen? Absolutely. So working on that at the same time that we are looking at the new CMS guidance and what those implications are for where we're going to need to come into compliance. And, we are going to be submitting and not submitting where we were in the same place of getting retroactive approval, right? So we're going to submit our implementation plan revision with a date that's in the future. And so then working through what additional trainings, documentation, all of that is going to have to be done to come into compliance with that new CMS guidance, as well as, continuing to support the LEAs with the training needs that currently exist so that they can come into, participating in the full expansion of the program. As I said, many of the LEAs still aren't kind of fully there. So I think for us, it'll be a little bit of all of the above, as we work through the next probably 2 years to kind of look toward the future and see what this means for us. We're a tiny state. I mean, Chicago is larger almost than our entire state. And so, we have a lot of really small LEAs that have very limited capacity with staff. So how do we really work to support them and ensure that this program is successful for them? I don't want states, I don't want LEAs to be in a payback situation. So for us, it's really going to be about just supporting those LEAs with the current program and then moving forward as well.
Thank you both so much. I see that there's questions. I know we could keep going, but I think we will be wrapping up now, and we'll try and get to some of these questions and follow up with any questions that we weren't able to get to after the webinar. And Christy and Kate, thank you both so much for being here. Kate, thank you. We'll be sending out this information after the webinar too, so you're and giving those numbers a little bit extra celebration emojis to go with it, but to you both. But thank you both for being here, and really just appreciate all the expertise and leadership and innovation that you've done in this area. Thanks.
Thanks for having us.
Thanks.
Absolutely, anytime.
Thanks. And with that, Elson, I'll turn it over to you to wrap us up, close us up.
Sure. And but yeah, thank you. Just to echo before we sign off, thank you again to all of our speakers today for providing so much insight and information for today's discussion. Anna, I think we can just skip to the last slide in consideration of time here. But just want to highlight that we'll be sharing out several different resources with you from our website, including but not limited to those that are listed here. And so in addition to today's recording and slides, we'll be sharing these resources with you, and we hope that these tools are helpful for you as you work to increase access to and funding for essential school-based health services to support child well-being. And next slide, Anna. And so as we close out today, please know that we welcome you to reach out and stay in touch with us. We're always here and happy to share resources, dig into any questions you have, and build connections across states. Please continue to follow us and stay connected to the Healthy Schools campaign via our social media networks and by going to our website, healthyschoolscampaign.org, where you can find even more resources and subscribe to our newsletters so that you can stay in touch and hear about future webinars and events that we'll be hosting. So yes, again, all resources will be sent to you as follow-up in the coming days. Thank you all so much for being here. We hope you enjoy the rest of your day.